All right, so radium-223, just a quick overview over 10 minutes. Dr. Gamella talked a lot about this. Radium-223, calcium mimetic, localizes the bones. It's a higher mass, so it has more energy, but the beauty of it is that it travels a shorter distance, so the side effect profile is a lot better, and it creates these double-stranded DNA breaks, which kills the prostate cancer cells. And as Lenny had showed, that it improves overall survival. So I'm going to take a little trick that I learned from my good friend Steve Finkelstein and say that 3 times. Improves overall survival, improves overall survival, improves overall survival. So yeah, where's Steven? All right, anyway, so it does not decrease, the primary endpoint wasn't to decrease bone pain. So, I think this still gets really confused, people get confused about that point. This time to first symptomatic skeletal event, Dr. Gamella talked about, so we'll skip that. So, when people thought about radium-223, that Alsimca trial, obviously it was a groundbreaking trial, and I think Dave was involved in the planning of it, and Nick Vogelsang here was the senior author on that. I mean, it was groundbreaking, and it was the first time a radiopharmaceutical was shown to improve overall survival. So, for a nuclear radiologist, this was a huge step forward and something that we were very excited about. So when you thought about the mechanism of action of radium-223, it really set up very nice to be used in combination. And the idea of using it with AR inhibitors was sort of the low-hanging fruit that a lot of people thought about. And when they created that expanded access trial, Fred Side and multiple others published on the use of the data that they gathered during that early access period, and their final conclusion was that it could be not only abiraterone and enzalutamide could be used safely, but it showed that maybe there was an improvement in overall survival in those patients who were treated with those drugs concomitantly. This was interesting because in Alsimca, none of those patients received abiraterone or enzalutamide because those drugs weren't approved during that accrual. But in the expanded access trial, patients were receiving abiraterone and enzalutamide, but typically in a layering fashion where they would be on that drug first and then you would add radium later. Eradicate, this is a small study from Dr. Shore, open label phase 2. It looked at radium plus abiraterone. Again, this wasn't started concurrently. There was a lead-in period. Patients usually got abiraterone first, and then radium-223 was added. This looked more at symptomatic bone, or looked at more bone pain and quality of life measures. And they used the bone pain index, and that showed that a decrease was seen in the bone pain severity scores. And 18 out of 31 patients had a greater than 30% reduction in pain. So this was nice. Not only was this drug improving overall survival, but there was this improvement in quality of life as well. So this was ERROR 223, large randomized multi-center trial, looked at patients with 2 or more bone mets, asymptomatic or mildly symptomatic patients, no prior chemo, randomized 1-to-1. These patients received abiraterone plus radium versus abiraterone plus placebo. I mean, a lot of us talked about this for years, and we sort of foresaw this being positive. But then in November 30, 2017, a lot of us received this letter that talked about this warning. So the Independent Data Monitoring Committee noticed an increased incidence of deaths and fractures in patients who were in the treatment arm. So they unblinded the study, and they released preliminarily that the incidence of fractures was 24% in the treatment arm versus 7%, and the percentage of deaths was 27% versus 20%. But this was the interim data that the preliminary data that they released. So then at ESMO in this past October, Matt Smith presented this in Munich that showed the final results for that study. The baseline characteristics were very similar between the two groups. Overall survival actually was not statistically significant, so there was no real survival difference between those patients who received the drug versus those who did not. So this was good news because it was better than what was preliminarily announced in November of 2017. Symptomatic skeletal event-free survival, that was not significant. The number of fractures was increased in those patients who received Abi plus radium versus those who received Abi plus placebo. Pathologic fractures were 3 times. What's interesting, though, is the greatest increase in fractures was the osteoporotic fractures. And you also saw an increase in the traumatic fractures. So I think it was sort of giving us a signal that, bone health is important. And Dr. Gamella talked about that very eloquently, that bone health is something that we really need to focus on. Another interesting point of data that came out of the final analysis was the fact that bone health agents really made a difference. Didn't completely eliminate the fracture risk, but it made a significant difference in those patients who were on denosumab or zoledronic acid versus those who did not. Personally, it was kind of shocking to see that a lot of patients actually weren't given these bone health agents while they were given radium. But I think that's another lesson that we can learn. This is a chart that I found that looked at Radium-223. Lots of information. The one thing I found that was pretty interesting was the number of fractures was actually greater in those who had less than 6 metastases. Because I think a lot of people assume those with a higher burden of bone mets would have a higher incidence of fractures, but that wasn't necessarily true. I think we could speculate with regards to why. Maybe it was these quote-unquote healthier patients who were doing more activities that led to more fractures, possibly. So this was the interim analysis. Fractures, this is the way it was reported. In the final analysis, again, fractures were still increased, but overall survival wasn't quite as bad as what was announced during the interim analysis. So conclusions, there was no significant change in overall survival, there was an increase in fractures, and bone health agents decreased fractures. So the final recommendation was not to use ABI and radium in combination. This is an interesting graphic that comes from Twitter about studies. So when a new study is released, if it validates your preconceived beliefs, then it must be a good study. And you were right all along and you're a genius. But if it doesn't validate your preconceived benefits, then it's a bad study. You find any flaw you can, and then it's a bad study, and you, again, feel like a genius. So, it's tricky, and a lot of people in industry probably, feel this, and it's an interesting, study on human behavior. So this was the final change in label, just included a warning about Radium-223 used in combination with abiraterone. So in the end, Chuck Ryan likes to sort of use this label, calling this trial a successful failure. There's so much to learn from this trial that I think it's silly just to say it's a failure and just to move on. There's a lot that we learned, and I think the biggest lesson that we're learning is the fact that bone health is important. And what Dr. Gamella talked about today is so vitally important to how we treat patients, and something that we need to continue to focus on, because that will improve outcomes and that will protect our patients. Because it's a success story because our castration-resistant prostate cancer patients are living longer than they ever have in the past. They're seeing longer courses of ADT, more prednisone, lots of other therapies. So you can imagine their bones are going to get more fragile, but we haven't really addressed that issue, and now we're seeing more attention being paid to that here in 2019, which is it's a step forward and something that we appreciate those patients who participated in these trials. Interestingly, if you look back at some prior trials, such as Cougar 301, this idea of increased fractures in patients who are in the treatment arm isn't new. So it's happened in the past as well. But again, this is just another reminder that we need to focus on the bones. So this idea of combination versus layering, I think, is an important topic. When we met and discussed RADAR-2, the topic of layering was introduced, which we heard about from Dr. Shore and Crawford early in this meeting. In Radium-223, I heard that 90% of those patients started those two drugs in a 24-hour period. So you can imagine the physiology for that is completely different from someone who's been on Radium-223, or abiraterone, then Radium-223 is at. I think this is an area that needs to be examined in the future, but we'll see if we can do that. PEACE-3 is an exciting trial that's very similar. It mimics Radium-223, but it uses enzalutamide as opposed to abiraterone. Once the data was released on Radium-223, this trial was modified to add denosumab and bone health agents to those patients, so which was good, and this will is scheduled to be completed in November 2019. So summary, targeted alpha therapies have an overall survival benefit. CRPC patients with symptomatic bone mets, Radium-223 is safe pre and post chemo. The combination isn't recommended. I think we can have a long discussion about that. Some patients can be started on that, and I think it's just a matter of having a good discussion, and I'm sure Dr. Vogel's going to have some comments about that. And bone health agents are critical to the treatment of our patients.